Okay, let's finish up the chapter. So the process of the process of infection and disease. So if you remember in a previous chapter, I talked about the different stages of bacterial or microbial growth. Well, I told you that if you learned that graph or that chart that we were going to see that again in later chapters. Well, here we are. And here we are going to talk about the 4 distinct stages of clinical infection. So the 4 distinct stages are, number 1, incubation period, number 2, prodromal stage, number 3, period of invasion, and then number 4, convalescence. So what occurs during incubation? Well, this is the time from your initial contact with the infectious agent to when you actually begin to see the first symptoms. Remember that the agent, the microbe, is probably multiplying, but you're not able to see any of the symptoms yet. So if we look at the chart, the graph that I told you about, remember that the incubation period would kind of follow that lag stage, wouldn't it? Right? So it's multiplying, but you don't really see any of the symptoms. So basically you've been exposed, but yet you're not really seeing any of the signs and symptoms. Okay, next stage, prodromal. Prodromal is the stage where I describe this as you're just not really feeling good. You can't really put your finger on what it is, you just know that you don't feel well. And so this is going to be vague feelings of discomfort, really non-specific complaints. You just kind of ache, you just don't feel good, your head kind of hurt, you can't really put your finger on what it is, you just know that something's not right. Well, then if we look at the prodromal stage, you start to see an increase in your symptoms, and then all of a sudden, boom, you have that period of invasion. Remember, this is when we called it exponential growth. And during this step, this is where it is at a high level. That microorganism is multiplying at high levels. It's becoming well established. The signs and the symptoms are there. The fever, the diarrhea, the vomiting, the body aches, you name it. You've all experienced it before. You absolutely probably feel like you're dying. You just feel awful, and you know that something's not right. And then we get to the height of the infection, and again, this stage right here can kind of vary. I'm just kind of showing it short, but it can vary in size. But basically, it's where the multiplication rate is equaling the death rate, so it's kind of stable. You're still feeling horrible, but you just aren't getting worse. And then you enter what is called the convalescence period, or the death phase. And not your death, but the microbe's death. And, excuse me, this is where the person begins to respond, starts to feel better, symptoms are declining. And honestly, guys, the convalescence period, there is no set amount of time. Different people, depending on what the condition is, convalescence can take a short period of time or a long period of time. But the key is this is usually, you definitely know you're feeling better, but very often we or our patients try to return back to, quote, normal too quickly, and we'll often see an escalation again as a result of it. So again, I mentioned this, it kind of follows the stages, stages of disease follows the bacterial growth curve as well. All right, infections. Well, you can have a localized infection, a systemic infection, a focal infection, and a mixed infection. So localized is just what it means. It means that it enters the body and it remains confined to a specific tissue. So if we look at this picture here, localized infection, let's say if someone has a boil under their arm, the infection is clearly localized just in that one area. Well, systemic is just that, system-wide, and it usually travels in the bloodstream. And so what are we going to see there? We're going to see that maybe for example, influenza. The influenza virus then travels completely throughout the body, and you just utterly feel horrible all over. Okay, this is the body aches, the malaise, the lethargy, you just feel horrible. Okay, well, what about focal infection? Well, this is when the infectious agent will break loose from one area and then get carried to other tissues. So, for example, in a focal infection, let's say you have strep throat, right? And then, one of the problems with that is that it then can go and affect the valves of the heart. It has like specific target areas. Certain bacteria just like to target, certain areas. Probably the most common kind is the mixed infection, which just means that several microbes can grow simultaneously at the infection site, and we call that polymicrobial. So very often we have mixed infections, and often mixed infections can sometimes lead, to what we call, you have a primary infection and then a secondary as a result of treating the primary infection, then the secondary infection shows up. So for example, ladies, if we take an antibiotic for, say, sinuses, or in this case they were showing a urinary infection, and you kill off those bacteria, then basically the fungus have a party, and they're very opportunistic. Remember, we're talking about Candida albicans, and then they just go crazy, and they then form that secondary infection. So again, these are some examples of patterns of infection. Acute infections means rapid onset. Short-lived, but comes on hard and fast. Chronic infections tend to be progressive and be persistent over a longer period of time. All right, signs and symptoms. A sign is something that can be objectively diagnosed. So a sign is something, the way I say it is, a sign is something that can be measured. Something that can be measured. A symptom is more subjective. Is more of a description. So for example, the patient will come in and they will have symptoms of chills, but we can then take a thermometer and actually take their fever, take their temperature, and we realize that they have a fever. The fever can be measured, therefore it is a sign. The symptom would be, for example, the chills. When somebody has septicemia, okay, so increased white blood count, or like in the case of leukocytosis, increased white blood count, they'll often have itching or pain or irritation. If there are microbes in fluids, they often feel nauseous. If the person complains of fatigue and malaise, you can do your osculations by listening to abnormal chest sounds. Again, leukopenia, that means, low white blood count. The person may experience headaches. Well, that's because they're not getting enough oxygen. I'm sorry. Then they may have oxygen issues. And so the lower white blood count, might be causing that. Tachycardia, increased heart rate. Very often the person's kind of anorexic in that they don't have an appetite. So again, signs can be measured. Symptoms are more descriptive. All right, some other signs and symptoms, things like fever, pain, soreness, swelling, edema, accumulation of fluid. You can have abscesses or granulomas, which would be inflammatory cells kind of isolated. You can have lymphadenitis, swollen lymph nodes. You can palpate and actually feel the swollen lymph nodes. If you have infections in the blood, by doing a CBC, a complete blood count, you can check to see what are the erythrocytes, the red blood cells, but you can also check your white blood count. Leukocytosis is an increase in white blood count. Leukopenia is a decrease in white blood count. Septicemia means that microorganisms are multiplying in the blood and thus are traveling all over the body. Bacteremia is the small number of bacteria present in the blood but not necessarily multiplying. Same thing, viremia, small number of viruses, but they're not necessarily multiplying. Then, on top of all that, sometimes infections go unnoticed. We say that they're asymptomatic or subclinical, and that means that the host doesn't show any of the signs or symptoms. And so because of that, they don't seek medical attention, and very often don't seek medical attention until, it finally manifests itself big enough that there's no denying that there's something going on. And then finally, portals of exit. So if something's going to enter, it's also got to exit. So remember that just like portals of entry, very often portals of exit are the same way. Respiratory and saliva portals, my goodness, absolutely one of the major exit points that gets us sick, communicable. Epithelial cells, believe it or not, sloughing off of skin and scalp cells. Fecal, my goodness, employees must wash hands before, well, of course. Fecal, just coming in contact with that increased load of microorganisms that are found in our lower GI. Urogenital tract, same thing, tying in with the fecal route. And then, of course, blood and bleeding. If somebody's bleeding, this is going to be a possible portal of exit. So, persistence of microbes. Sometimes microbes can be said to go latent or go into latency, and it's after the initial symptoms in a chronic disease. Sometimes they will kind of go dormant, right? And because they go dormant, they're not really seen, and then they reemerge. So again, like in the case of viruses, they can go lysogenic, which is, they kind of go into that dormant state, latent state, and then they go lytic or active. Very often somebody can be a carrier, right? Person with a latent infection, a hidden infection, who sheds that infectious agent and doesn't even realize that, they're a carrier. Remember that when you carry infections, you often have sequela, which is long-term or permanent damage to tissues and organs. And then finally, we kind of wrap up with this idea of epidemiology and how infections are spread. And remember, the epidemiology is going to be the study of the frequency and distribution of disease. It's not just micro. You have to understand anatomy, physiology, immunology, psychology, medicine, sociology, ecology, and of course you've got to have mathematicians and statisticians to keep track of it. And then it considers that many diseases are not necessarily infectious ones, but then they lead to transmission as well, just because of the compromised state of the host. And these would be things like heart disease, cancer, drug addiction, and mental illness. So when we're thinking about transmission, we often think, well, who's the reservoir or who's the source? Where is this normally found? Where's it located? What is the primary habitat of this particular pathogen? For example, if you said, Miss Bradley, if you go to India, don't drink the water. Well, that's because the water is often the reservoir for things like cholera, okay, or Vibrio cholera. And so because of that, if you understand where the reservoir is or where the source is, and especially in infectious disease, you want to try to identify the source, then that's going to help control transmission. Remember that carriers is any individual who inconspicuously shelters the pathogen. Some carriers are asymptomatic, which means they don't show any symptoms. Some are passive. Bless y'all's heart, some of you are going to become passive carriers. I hope you don't, but you do. And that's where, think about it, you're so busy, and you go from one patient to the next, and you could accidentally be a passive carrier of microbes from one patient to the other, and obviously not meaning to, but just by virtue of the fact that y'all are overworked and are having to multitask constantly. Some are incubation carriers. They spread the infectious agent during the incubation time. Some are convalescent carriers. They recuperate without any of the symptoms. Some are chronic carriers. They can carry it for long, long periods of time. So here we go. Here's a concept question. If a nurse transfers a pathogen between patients without becoming infected herself, the nurse acted as what? So she transfers the pathogen but doesn't become infected herself. Okay, she would be considered a passive carrier. All right, I'm going to stop here and then finish up.